Hey ubba-bubba, welcome to 1MD. I'm going through some Amboss questions in gastrointestinal system, pedia, and infectious disease. And I blurred the image, but I'm going to be studying out loud. So without further ado, let's do it. So how I do questions is I usually start with the last part, and then I read the question. Because at least knowing the last part will help me frame the whole question in my head. So let's do this. Which of the following tests is most likely to diagnose the patient's underlying disorder? So it's a diagnostic question. We have to think of how we are going to check the patient for his condition. Okay, so we have a 14-year-old boy. He is brought to the physician by his parents for a well-child visit. So he's okay, more or less. Or at least his parents think he's okay. He's born at 38 weeks, gestation, vaginal delivery, healthy except for occasional episodes of asthma. He attends junior high school and is having difficulties keeping up with his classmates in many classes, yet 97 percentile for height, 50th in weight. He uses an albuterol inhaler. Immunizations are up to date. Vital signs are within normal limits. Cardiac exam shows a high-frequency mid-systolic click. Best heard at the left fifth intercostal space. Right. Mid-systolic, mitral valve. Systolic murmurs can be, what do you call this? Can be benign. He has long extremities along with excess breast tissue bilaterally. Oh, he's 14. No axillary hair. Reduced scrotal size and a normal sized penis. Alright. Kid is good. We don't have to do IGF measurement. That's not necessarily necessary. We don't have to do a southern blot because we are not suspecting any HIV infection. Mention any problems. Okay, he has a mid-systolic click. About bone age. Bone age is valid. Urinalysis, I don't see why we have to do that. Slit lamp exam. Does he show any signs of any inflammatory disease? Any osteodystrophy? Any malnutrition? I do not see any. Karyotyping. Why would we want to do karyotyping? I'd go with bone age. No! It's not the right Klinefelter. Okay, so that's it. That's the only thing. He has really tall. He has a high frequency mid-systolic click. And he has reduced scrotal size. So double XY. I should have seen that coming. But I didn't. But I coulda. Okay. Learned my lesson. Let's go to the next one. Which of the following is the most appropriate initial step in the management of this patient? We have a 26-year-old man. He comes for a routine health maintenance examination. He feels well. Type 1 diabetes, insulin, immigrated from Nepal to start a new job. He immigrated 4 weeks ago to start a new job as a software company manager. He smoked 1 pack of cigs daily for the past 5 years. Tell him to stop. But, okay, let's keep going. He doesn't use alcohol or illicit drugs. He hasn't received any routine childhood vaccinations. He appears healthy, well-nourished. BMI is 23. Temperature is 36. I think this is going to be a TB question, but anyway. Pulse is 72. Blood pressure is 123/82. No abnormalities on physical exam. PPD is administered. We have an induration of 12. Let's do an x-ray. So, okay, I'm guessing for these, you have to do the x-ray first. If the x-ray is benign, then you can just offer to do isoniazid, maybe vitamin B6, rifampin? Rifampicine. But if the x-ray is positive, then you'd have to do the 5-pill therapy. No, it's actually 4 now. They removed that last one. Streptomycin. Why don't they do streptomycin anymore? I can't remember. X-ray of the chest is shown. Let's check the x-ray. Well, I can see the x-ray, but you can't. So if there's a node, I'll just do 2-month management. If there's no node, then I give... Wait, if there's a node, I give 4x management. And then if there's no node, I do isoniazid and rifampicin. Well, actually, okay, I don't see no node, but there was no fourfold measurement inside the x-ray results. So, I mean, I could just go with rifampicin. Sweet sauce! Oh, it's 3 months, not 2 months. What do we do for 2 months? Okay. Noted. So the 2 months is only quadruple therapy in management of active TB. To the 2 months, and then you do 4 more months of twice therapy. Got it. Let's do the next one. All right. Oh, it's a cardio question of a kitty. Let's see if we can answer it without doing auscultation first. So, which is the most likely diagnosis of a 1-year-old male newborn examined in the nursery, born at 35 weeks to a 27-year-old woman? So he's pre-term. Mom had not had routine prenatal care. Sketchy. She has a self-limiting reddish rash, started on her face, spread to her trunk and limbs. Viral exanthem, I think. Right. Joint pain in her hands, wrists, ankles, 2 weeks into the pregnancy. Okay. I'm thinking mitral. Let's hear it out though. I'm not sure. What would it do? It would cause cardiac enlargement, maybe? Let's cheat. Let's see. We have a holosystolic murmur. Holosystolic murmur. So what virus would cause a holosystolic murmur? Okay, I mean, I didn't really need to think of that. Let's see. Atrial septal defect. I mean, of course I needed to think about it, but I think it's atrial septal defect. No! Okay, it's a machine-like murmur. I'm sorry. It's a continuous murmur heard at the left upper sternum border and has a machine-like purr. Sounds like that. So I need to work on the hearing, but it's a ductus arteriosus. Got it. But okay, so this can be caused by viral rubella. Of course. Okay. Rubella causes patent ductus arteriosus. I forgot that association, but I should reassociate that association. Okay, got it. Wouldn't it be fun to like troll? Okay. I just got an SMS from one of those spoofers. What they did is they hijacked the number of my telco and they sent me a link saying that I had like 7,000 plus points to claim. with a sketchy link attached. I know what to do. Click on the link. No, I'm kidding. Never click those links. Okay, which of the following is the next step, appropriate next step in management? 55-year-old man comes to the physician for a follow-up exam. He had mild itching during the past month, cirrhosis, hypertension, and GERD. Okay, I think there's like an esophageal varix somewhere. He used to drink a pack of vodka and multiple beers daily, but he quit 4 months ago. Sir! You quit and you were older than 50. I'm sorry, but it seems like the damage has been done at this point. Current medications include ramipril, esomeprazole, vitamin B supplements. He appears thin. Ooh, that's cirrhotic. Rending of the palms, several telangiectasias, enlargement of the breast tissue. Testes are tiny and firm. Okay, ultrasonography shows a nodular liver surface with atrophy of the right lobe. I think all else considered, I would want to do a transplantation. But okay, let's check the liver values. Yeah, let's do a CT. No, but let's check the liver. Okay, let's check the liver values first. It's positive for HAV, IgG antibody. The liver values are slightly normal. He has increased indirect bilirubin. His platelets are low. Okay, let's see. What do we want to do? Let's do a CT. Why do you want to do alpha proteins in 3 months? I'll get, wait, did we do an endoscopy? Yeah, there's no, okay, no varices. In 3 months, what can we do to help him now? Hepatitis A vaccine? Will he be leaving anytime soon? I think not. Hepatic biopsy? How can we do a biopsy if we don't do a CT? Abdominal ultrasound in 6 months. Let's do the CT. No! Okay, what's the answer, poop face? Okay, the answer is to do an ultrasound in 6 months. Why? On the rate of growth, independent of individual risk, all patients with alcoholic cirrhosis. You know, this is a 4-hammer question. Let's be real. I would... Oh, come on. Okay, why don't we do a CT? Primary screening tool for detection of patients with cirrhosis because they... Oh, they're not the primary screening tool. Okay, it's indicated when you see a nodule. I don't know. I should just follow the logic here. Okay, it's a 6-month interval, universally based on the typical rate of HCC tumor. Okay, so you're gonna wait for the tumor to grow before you do an ultrasound? I don't know, really. Okay, all patients with cirrhosis should undergo a screening endoscopy to look for esophageal varices and determine the risk of variceal bleeding. But we did that. Okay, yeah, we did that. You should also like state that it's part of what we did before giving the conclusion. Okay, it's a 6-month interval, but that's what you're trying to teach me here. Okay. Which of the following is the most likely causal organism? So we have either GI, pedia, and ID are all very highly associated with the ID. So I shall not make a distinction at this point. Okay, it speeds. Previously healthy 10-year-old 10-day-old May, newborn, is brought to the doctor by his by his mother because of episodes of weakness and spasms for the past 12 hours. Mommy says that he's difficulty feeding and opening his mouth. He has not had fever. Okay, he's had difficulty opening his mouth. Not had fever, cough, diarrhea, vomiting. Born at 32 weeks. Uncomplicated delivery at home. Ooh, wait a minute. Oh, she gave him raw honey. No, his sister gave him raw honey. Botulism. It has to be botulism. Mommy refused vaccines. Why did you... Right, he's 10 days old. At this point, you wouldn't really have given him anything except for hepatitis B. And if you live in the Philippines, PPD. Although I'm not sure if they still do that. PPD. BCG. But I'm not sure if you still do that. Stiffness, twitches. Okay, stiff, twitchy, soft and flat fontanelles. What am I doing? Botulism. What? Okay, it's the spastic versus flaccid, but let's keep going. Which of the following is the most likely cause of this patient's skin findings? Skin findings. It's infectious. 48-year-old man with HIV infection comes to the doctor because of skin lesions over his face and neck for 2 weeks. Not itchy or painful. He does not have fever or sore throat. He was treated for candida esophagitis 3 months ago. Okay. He's sexually active with his wife, who knows about his condition. They use condoms consistently. He's currently receiving anti-triple retroviral therapy. Triple antiretroviral therapy. He's 175 centimeters tall, weighs 58 kilograms. BMI is 19. He has multiple skin-colored papules over his face and neck with a dimpled center. Ooh, dimple. Sounds like it's that cute name. I forget. Pox virus. Is it pox virus? It's pox virus. Yes. Right, molluscum. To be honest, it sounds really delicious, but it's really infectious as well. I'm not gonna be eating seared molluscum anytime soon. Although seared mollusks sounds really good right about now. Okay, what's the following is the most appropriate step in management? Elevated liver function tests that were found during routine screening. Headaches over the past year, otherwise feels well. Patient reports that he was involved in a severe car accident 35 years ago. His dad had a history of alcoholism and died of liver cancer. He takes no meds and has no known allergies. Okay, yeah, usually. Does he? Okay, doesn't drink alcohol. Temperature is 37.8 C. Okay, he has mononuclear infiltrates limited to portal tracts and periportal hepatocyte necrosis. Portal tracts. Let's see. Okay, now the hepatitis RNA is positive. The hepatitis C antibody is positive. He has hepatitis C. I'd go with So fosbuvir and ledipasvir. Sweet sauce! Wait, this was a four-hammer question? Seriously? Interesting. Well, I mean, I didn't like go through like all of the mechanism of action and all of that stuff, but I remember it. Entecavir goes to hepatitis B, and sofosbuvir goes to hepatitis C, which is kind of ironic because one of them has the B and one of them has the C. So I could think of it like B versus C and C versus B, I guess. But anyway, that works. Let's go. Which of the following is the most appropriate next step in management? A 15-month-old girl brought to the emergency department after a 2-minute episode of rhythmic eye blinking and uncontrolled shaking of all limbs. She was unresponsive during the episode. For the past few days, the girl has had a fever and nasal congestion. Immunizations are up to date. Temperature is 39. Pulse is 110. Respiration is 28. And blood pressure is low normal. She is sleepy but opens her eyes when she's called. She has moist mucous membranes. There's no abnormalities on neuro exam. Neck has a normal range of motion. Oral dose of acetaminophen, paracetamol, is administered, and on reevaluation, she is alert and playing with toys. Discharge. Let's do a discharge. I would not do a CT of the head. Yeah, I don't have to admit her. Why give a lorazepam? She's like 15 months old. Don't do a lumbar puncture. I do a discharge. Discharge! She had a febrile seizure. So just give her paracetamol. That's it. That's it. Simple as that. Okay. Underlying etiology of this patient's illness. A 2-year-old boy is brought to the physician with increasing productive cough with a moderate amount of white phlegm for the past week. He's been treated for pneumonia with antibiotic therapy 4 times over the past year. So he has recurrent infections. Chest x-ray performed 3 months ago showed no anatomical. So it's an anatomy problem. It's a white blood cell problem. He has had multiple episodes of foul-smelling, bulky, greasy stools. Is this cystic fibrosis? He's at 3rd percentile for height, 5th percentile for weight, so he's pretty short. Temperature is 38. He has pulse of 132, resp is 44, inspiratory crackles throughout all the lung fields. Which of the following is the best initial test? Let's do a chloride test. Yes! It's a chloride test. Oh yeah. Next. This patient's condition is most likely associated with which of the following findings? So, we have a 71-year-old man who comes to the physician because of a 2-day history of rash across his trunk and extremities. For the past 3 months, he's had persistent pruritus. Still don't know how to pronounce it. Let's see. This is taking forever. My internet is particularly slow today. Maybe it's because of the rain. Yes, I want to quit, you poop face. Okay, Google. How do you pronounce pruritus? See, even my phone's slow right now. Anyway, the rash across his trunk and extremities, back in the woods. with his grandson last week to try to lose weight. His grandson, who spends the week with him, recently had impetigo. How recent is recent? He was treated for gout. He has hypertension, hyperlipidemia, and limb osteoarthritis. He was treated for gout 5 months ago with he has attacked in the left big toe, hallux. Current medications include captopril, hydrochlorothiazide, simvastatin, allopurinol, and ibuprofen. There are diffuse vesicles and tense blisters involving the chest, flexures, and shoulders. Rubbing of the skin does not produce blisters. So, the blisters, it is full thickness necrosis. I think it's bullous pemphigoid. Okay, let's go through it. Gram-positive bacteria in urine? No. Antibodies to VZV. It's the whole chest and arm flexures and shoulders. It's not isolated to a single dermatome. No. Desmoglein. If it's antibodies to desmoglein. Oh, wait a minute. Wait. Desmoglein. Is that the one with hemidesmosomes? No. Desmoglein is the desmosomes, right? Anti-tissue transglutaminase, that is that food thing. Celiac disease, no. Growth of HSV1 on viral culture from blisters, no. Linear deposits along the basement membrane on the direct. That's coughing. Spongiodic dermatitis. Okay, no, this is not full thickness necrosis, because full thickness necrosis would create blisters. So it's desmoglein. No! I was right that first time. Not even! Oh my gosh. Are you pooping me? Okay. Linear deposits of IgG and C3 on the basement membrane. Urticarial lesions. Okay, what's the disease? It's autoimmune. Okay, it's bullous pemphigoid. Is it? What's the disease? Okay, it's bullous pemphigoid. Okay, bullous pemphigoid is not infectious. No, it is caused by infectious, but is it? No. Let's see. Ah! You poopy do. It's a good thing that's blurred, because you wouldn't want it to have seen that unless you're a doctor or a med student. Let's see. Well, I'll see. You'll see a hint of it because it's blurred. So, okay. These are hypersensitivity reactions. Poop. Okay. So pemphigus vulgaris happens at 40 to 60. It's more fatal. What did I answer? Okay, so the correct answer was linear IgG and C3. So IgG and complement. So it's both type 4 and type 3. Interesting. Alright, let's go. Physical examination of this patient is about to show, most likely to show which of the following findings. An 8-year-old boy is brought to the physician by his parents because of repeated episodes of daydreaming in the past 2 months. Parents are bringing their kids to the doctor for daydreaming. Mommy reports that during the episodes, boy abruptly stops what he's doing and stares out into space. Mom, he's not daydreaming. He has a seizure. He smacks his lips. Initially, okay. Lasts 1 to 2 minutes. They occur 2 to 3 times a week. Initially, he only experienced the symptoms at school, but last week he had an episode while playing baseball with his dad. When his dad tried to talk to him, he didn't listen, and after the episode, he was confused for 10 minutes and too tired to play. The patient has been healthy, except for an episode of otitis media a year ago that was treated with amoxicillin. Further exam is likely to show which of the following. Defiant behavior? Not really. Difficulty sustaining attention during tests? I'll put a pin on that. Impairment in communication and social interaction? Not really. Temporal lobe spikes? That's promising. Conductive hearing loss? You managed the otitis media with amoxicillin and he hasn't had a repeat episode. It's not likely that this episode is due to the amoxicillin. Normal neurodevelopment? Okay, slow wave complexes on ictal EEG. Not really. That's like a sleeping thing. Okay, so my 3 choices are difficulty sustaining attention, temporal lobe spikes, and normal neural development. I mean, technically this kid will develop normally. And it's possible that other than these episodes. Okay, no. The frequency is happening 2 to 3 times a week. I wouldn't call that normal. Difficulty sustaining attention during tasks. He won't be able to perform tasks when he has these episodes. So I'll say temporal lobe spikes. Sweet sauce! I got it. Although that was more neuro than pedia, I think. Anyway, let's go. Which of the following is the most appropriate assessment of her development? So we're looking at motor, both fine and gross, language, and social skills. Okay. We have a 13-month-old girl brought to the doctor for a well child exam, born at term, 38 weeks, no family history of illness, cannot pull herself to stand from a sitting position. Oh my goodness, the gross is delayed. No, the gross is delayed. Gross. It's gross. Okay, gross is delayed. Where am I? Pick an object between her thumb and index finger, but can't feed herself using a spoon. Sounds delayed. She comes when she's called by name. Language is good so far. She's willing to play a ball and she looks after it for it being hidden. She looks for it after being hidden. Cries if she doesn't see her parents in the same room. So separation anxiety. She babbles. Oh, the language seems delayed. She'd at least be making neologisms at this point. So I'd go with F. Let's see. Social skills. Well, she cries if she's not with her parents, so they're definitely not delayed. So is the language delayed? Well, fine is not delayed, so let's go with F. Sweet sauce! Language is definitely delayed. She should not be babbling at this point. She should be making neologisms. Let's see. She used specific sounds to refer to people. So mama and dada. Right. Do they make neologisms at this point? No, that would be later on during the 1-year-old period. Anyway, good so far. Let's go to the next one. Most appropriate pharmacotherapy. 51-year-old man comes to the physician because of a 1-day history of progressive pain, hearing, blurry vision of the right eye. Noticed his symptoms last evening while he was watching a movie at a theater. Okay, pain, hearing, and blurry vision of the left eye. 1-day history. This sounds like a glaucoma. Left eye is asymptomatic. He wears contact lenses. That adds a confounder. Let's see, contact lenses. It could be scratching. Atopic dermatitis treated with hydrocortisone. Pupils are equal and reactive to light. Okay, that rules out glaucoma. Conjunctival injection. Whitish exudate at the bottom of the anterior chamber. Round corneal infiltrate. Sounds infectious. Okay, she wears contact lenses. Is that Pseudomonas? What do you give her? Pseudomonas infection. Don't give ketorolac. Cyclovir, nah. Again, cyclovir. Well, ofloxacin. Yes! Sweet sauce! I got it! Alright, let's go to the next one. What do you guys think of my falsetto sweet sauce? Let me know in the comments. Which of the following is the most appropriate next step in management? 7-year-old boy brought to the doctor by his mom has a 1-month history of bedwetting, 2 to 3 times per week. So regression. She and his dad have been monitoring the avoiding habits over the past month. He has a normal color and consistency of stool, and he avoids his bladder 5 to 7 times per day. I'm sensing a little. No, he drinks little during dinner and before going to bed. Not noticed any urgency, hesitancy, straining, post-micturition dribble, or episodes of urinary incontinence during the day. He has no pain, abdominal region, prior to, during, or after voiding. He recently started primary school and he enjoys it. Okay, nothing psychiatric either. He can balance, hop on a foot, tie a knot, name 6 colors, dressed with minimal assistance from his parents. He is at the 50th percentile. Vital signs are within normal limits. Physical exam shows no abnormalities. I'd go with enuresis alarm. Not really. No. Desmopressin? No way. The guy already doesn't drink enough. Avoiding cystourethrogram. You could previously do it, so no. Urinalysis. Vitals are normal. I don't think there's any problem. So it's about between enuresis and reassurance and follow-up. I'd go with reassurance. No! Not even? Enuresis? Okay, desmopressin. Not even? Oh my gosh. It's a urinalysis. So you need to exclude organic causes. Okay, so essentially the question is like, let's do a urinalysis, but you're fine. You're fine. We can just, do the lifestyle modification, psychoeducation, and any management of existing conditions. But let's just do your analysis, just to be sure. Oh boy. Okay, got it. Most appropriate next step in management of a 5-month-old girl who was brought to the doctor because of a red lesion on her scalp that was first noticed 2 months ago. Okay. Slowly increasing in size, not associated with pain, pruritus, born at 37 weeks gestation after uncomplicated pregnancy and delivery. Older sister is undergoing treatment for fungal infection of her feet. Vertex blanches with the soft lesion on the vertex of the scalp that blanches with pressure. Photograph of the lesion is shown. Which of the following is the most appropriate next step in management? A chill. Yes! So it's a hemangioma. Okay, at this point, I really want to see how you pronounce it. Pruritus pronunciation. Oh, okay. This is how you pronounce it. This is how you pronounce it.
Pruritus.
I see.
Pruritus.
It's fun to say. Pruritus. Anyway, let's keep going. Most likely cause of this patient's abnormal renal laboratory findings. Renal, so it's a kidney problem. In a kidney. In a kid. A kidney problem in a kid. A 9-year-old boy brought to the emergency department for the evaluation of diarrhea and vomiting for the last 2 days. He's had about 12 watery, non-bloody bowel movements and vomited 3 times. He's not able to eat anything since the symptoms started. He's not urinated since yesterday. Came back from a trip from India 3 days ago where he and his family were visiting relatives. He appears pale. His temperature is 38, pulse is 106. Okay, so he's febrile, he's compensating. Well, he's 9 years old. 106 would still be, I guess, within okay blood rate range, heart rate range, I guess. Let's see. Dry mucous membranes, he's dehydrated. No organomegaly, hyperactive bowel sounds. Lab studies show. What did the lab studies show? Okay. Okay, he's acidotic. Glucose is at 90. Urea nitrogen is high. How's the creatinine? Ooh, it's a blood urea nitrogen creatinine ratio of 40. It's huge. Okay, let's see. Okay, wait. He's acidotic. But the kidney, the potassium is low, 3.7. Oh gosh, wait, let's see. Diarrhea, vomiting in 2 days. Watery, non-bloody bowel movements, vomited 3 times, has not been able to eat anything. Had not urinated since yesterday, came back from a trip from India, where he and his family were visiting relatives. I'd say decreased renal perfusion. Sweet! Okay. Yeah, if the blood urea nitrogen and creatinine ratio is high, then you can expect a problem that is upstream of the nephron. Of the nephron? Of the glomerulus. Right. So it's upstream of the glomerulus, and because of that, the filtration isn't that high. So what's happening is you're keeping too much of the nitrogen and the creatinine, but relative to creatinine, the body really does produce more urine nitrogen. Because I mean, the creatinine is mostly from the muscles, and the urine nitrogen is from the amino acids. Yes. I guess so. Yeah, because you have the uric acid and then you attach a nitrogen base and then it's uric. I think. I'll have to review that. But anyway, let's see. Let's look at the blood rate, the heart rate. Vital signs. Let's look at pediatric vital signs. Okay. Oh, where's the heart rate? Yeah, yeah. So about that age, he'd still be normal up to 118 beats per minute. Sweet. Okay, let's go. Let's go. Okay. I want another coffee. Wait a minute. Give me back. Give me back. Some time. More coffee for me.
Coffee, 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 coffee. I get out of my bed and my eye bag's feeling heavy. I get into the car after I get my school things ready. I head for the cashier and then I give the guy my money. And then I get myself a can of coffee, 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 coffee.
Coffee is delicious. Cheers, everyone. All right. Coffee. Okay, let's keep going. Which of the following is most likely diagnosis? So, which of the following is the most likely diagnosis? Retinitis, keratitis. Okay, so I guess we're looking at the itis. A 34-year-old man with AIDS comes to the physician because of a 2-day history of decreasing vision and seeing the black spouts in the eye. He has no pain. Left eye is asymptomatic. He was treated for fungal esophagitis 6 months ago with fluconazole, so it's a fungal infection. Diagnosed with Kaposi sarcoma 2 years ago, so he takes his meds. Oh, wait, the antivirals, so efavirenz, tenofovir, and ticagrelor. He also takes azithromycin, that's probably for some prophylaxis of some sort. Trimethoprim, sulfamethoxazole, or how I like to call it, Timpi mix, multivitamins, and a nutritional supplement. Why don't you just say nutritional supplements? Anyway, let's see. He is 170 cm, 45 kilograms. BMI is low at 16. Temperature is 37. Pulse is 89. And his blood pressure is 110/70. He has cervical lymphadenopathy. Multiple violaceous plaques seen over the trunk and extremities. He has granular yellow-white opacities in the retinal vessels and multiple areas of blood hemorrhages. It's a retinopathy. It wouldn't be keratitis. Is it retinitis? Let's double check. I'd say retinopathy. Doesn't look infectious. VZV? Not really, no. Not toxoplasma. Is it CMV? It's retinopathy. No! It's CMV. Cytomegalovirus is an AIDS-defining condition that commonly infects patients with a really low CD4, less than 50. Okay, they have a pizza pie appearance because of a distinct mixture of red and white lesions, retinal hemorrhages, white spots. Okay, I see. So it looks like I think of CMV retinitis when I see this Pokemon by Veltal. CMV retinitis. Alright. Let's go. The next one. Come on. You gotta keep moving. Keep moving. Alright. Most likely explanation for this pain is thrombocytopenia. With fatigue. Trousers do not fit him anymore, as his waist has increased in size during this time. He has not seen his primary care physician for 7 years. He takes no meds. Erythema in both palms. Okay. Cirrhosis. Okay, what's the cause for his thrombocytopenia? Bone marrow infiltration, uremia. Uremia. I think it's uremia. Hyposplenism, no. Antibody-mediated destruction, no. My bet is the uremia. Now bone marrow infiltration. Okay, is it thrombotic microangiopathy? I think it's microangiopathy. Not so much uremia. I think the uremia would follow. If it was that intense, he would have like worse symptoms by now. Oh, it's the uremia. Not even. Okay, like what is it then? Okay, it's the hypersplenism. Well, what do you know? So, platelet sequestration, premature destruction. If you are a student of mine who is watching this video, I hope this shows you that though I am already a doctor, am learning just as much as you guys are. You know, all of us are in a continuous process of learning. When you chose medicine, it's a perpetual learning profession. You know, you can't stop learning. The point you stop learning is the point that you become a terrible doctor. So you have to keep learning new stuff. You know, that's the only way you grow, by learning. And that applies even outside medicine. You know, if you don't learn from your mistakes, then you're as good as poop. You stay poop for the rest of your life. 45-year-old man comes to the physician because of evaluation of painful swallowing and retrosternal chest pain. What's the most likely underlying cause of this patient's condition? Okay. Retrosternal chest pain. He was recently diagnosed with HIV. He takes triple therapy. He has no family history of serious illness. At this point, I'm thinking either CMV, esophageal candidiasis, or HSV. But anyway, let's see. CD4 lymphocyte count is 80. Does not use illicit drugs. He does not use illicit drugs. He drinks 2 to 3 beers per day. Sir, why are you doing this to yourself? There are no abnormalities in the oral cavity. Okay, there are well circumscribed, round, superficial ulcers in the upper esophagus. It's not candida. It's not allergic inflammation of the esophagus. It's not esophageal sphincter relaxation. Because if that was the case, then the lesion would be in the lower esophagus. It's not an adverse event. I would think that it's an infectious cause first before medication problem. I'd say CMV. No, HSV. It's HSV. HSV. Oh gosh, in my head I was like thinking HSV first. I should have gone with my first guess. Okay. Superficial ulcers. These 4 hammer questions are terrible, but at least I'm learning. I'm learning. Vesicles, multiple small, superficial, round, ovoid ulcers in the mid-esophagus. Mid-esophagus, but we were saying upper esophagus. Most likely diagnosis of a 6-month-old girl who was brought to the doctor because of a 2-month history of noisy breathing. Breathing has become progressively louder during this time. It's worse when she's lying on her back. Feeding, crying. Improves when she's placed on her belly, on her abdomen. Baby girl has been regurgitating milk more than usual for the past few days. Okay. Worse when she is on her back. So it's a positional thing. It's a structural thing. It's not so much a food allergy because either on her back or on her belly she'd have the same thing. If it was a foreign body aspiration, it would like kill her because it's been 2 months already. Cruel. It's not cruel. There's no coughing. Laryngomalacia or vascular array. I'd say laryngomalacia because by putting her on her belly, then you free up the space that's in front of her epiglottis and you enlarge the breathing tube. Sweet sauce is laryngomalacia. Got it. No, the next one. Most likely to confirm the diagnosis of an 8-month-old girl who was brought to the emergency department because of fever, vomiting, and diarrhea for 3 days. Parents report at least 10 watery stools daily. She's had 3 upper respiratory tract infections. She started daycare 2 months ago, but otherwise been developing normally. So she has watery stools and upper respiratory tract infections. And fever. Wait, 3 days. Okay. Wait, so let's see. Yeah. Okay, so 2 months ago she had 3 upper respiratory tract infections. Now she's had fever, vomiting, and diarrhea for 3 days. Mommy has a history of celiac disease. She's in the average height, so 57 height, 65th weight. Immunizations are incomplete. Temperature is 38.5. Pulse is 145. Blood pressure is 92/54. There's dry mucous membranes, decreased skin turgor. Bowel sounds are hyperactive. Most likely to confirm the diagnosis. Okay, so she's in daycare. What's gonna cause watery stools, diarrhea in a patient who is in daycare? I think rota, adeno, poliovirus, virus. Okay, it's not a structural thing. It's not an ultrasound. That's not gonna fix it. Blood cultures. It's going to do an idea. It's gonna give you an idea of what's causing the diarrhea, but it's not so much gonna confirm it. Serum IgG. I'll put a pen on that. Ova and parasites. Let's put a pen on that too. Gastrointestinal endoscopy upper. I would not consider it because it's more of a diarrhea thing. And she hasn't been vomiting anyway. Enzyme immunoassay. That is tempting. How about an immunoassay? I mean, if it's a GI thing, then the viruses were causing that, then it would show enzymes. Okay, wait. Complete blood count is in the reference range. That takes ova and parasites out of the picture. Serum immunoglobulins. If the blood count is normal, then you wouldn't expect a change in her serum immunoglobulins, especially if the lymphocyte count was normal. So I'd go with enzyme immunoassay. Sweet sauce! Yeah, that's it. Rotavirus. There we go. Thought so! Alright, let's go to the next one. Which of the following health maintenance recommendations is most appropriate at this time? 24-year-old man. Winter. Usually if it's winter, then you're gonna do a flu vaccine. Last seen by the doctor 12 months ago, up to date with vaccines, but he has no documentation of papillomavirus vaccination. No planned travel. Prior to starting college, he was appropriately vaccinated prior to living in residential dormitory housing. No serious illness, no medications, no abnormalities on PE. So first, we're not going to give meningococcus because we gave that already. Haemophilus influenzae? No, because he already has up-to-date childhood vaccines. So definitely we're gonna give influenza and papilloma. Sweet sauce! Don't you guys like it when I say sweet sauce in falsetto? I think I asked that already. Anyway. Final 10. Let's see. Further evaluation is likely to show which of the following in the patient. 32-year-old woman, worm. I'm sorry, all the females out there. I love you all. Especially my mom. I love my mom the most. But one day there's going to be a female whom I love more than my mom. But until that happens, I love my mom. And I don't think that's going to happen soon because I'm not quite in the mood to date yet. Let's see. Where was I? 32-year-old woman comes to the physician because of recurrent episodes of abdominal pain, bloating, and loose stools with mucus, lasting several days to a couple of weeks. Right off the get-go, I think this is a Giardia infection. But let's see. She has these episodes since she's... Oh, no. It's been chronic. Since she was 24... Oh, wait. It's episodic, so it happens a few weeks at a time, and it's recurrent. It's not Giardia. She's had it since she was 24, but they have worsened in the last 6 weeks. Okay, I think it's inflammatory bowel disease. Yes, but which kind? Site and intensity varies. So if it can't make its mind up on where it's going to say, it's probably Crohn's, because crows fly everywhere. She's had around 3 to 4 bowel movements per day during these episodes. Menses are regular, 31-day intervals, moderate flow, moderate pain in her lower abdomen during menses. Dysmenorrhea. Although I wouldn't rule out the possibility that there may... Okay, no, the anastomosis is going to form sometime later in life, not as early as now. She moved to a different city 2 months ago to start a new demanding job. She doesn't smoke, drink. Her medications include multivitamins and naproxen for pain. Okay, evaluation's gonna show which of the following in the patient. Right off the get-go, I think it's Crohn's disease. Weight loss. That's a viable answer. Cutaneous flushing. Not really. Wait. Wait a minute. Okay, weight loss is viable if it's Crohn's disease. Wait, how was the physical exam? Is she dry? Didn't say. Cutaneous flushing, that would be viable if we had VIP. Oma. Black tarry stools? No. It's loose stools with mucus, but there's no blood. Bright red blood in the stool? Not really. She's only 32. Relief of pain after defecation? No. Normal pain at night? Wouldn't say so. Okay. At this point... Okay, let's see. Wait, ESR is only 15. Where does that put us? Where's ESR? Okay. For a female, it's 0 to 20. So ESR is normal. Okay. So it's either cutaneous flushing because the ESR is normal, or weight loss because the pain keeps on switching location. Wait, during menstruation, what does that imply? There's a hormonal thing that's intensifying the pain. If it's a hormonal thing that's intensifying the pain, then could it be VIP? You know what? I'm going to put weight loss. No, it's cutaneous flushing. Not even. Relief of pain after defecation. Oh, poop. Okay. Why? Okay. Okay. So essentially, there are no red flag symptoms. So nighttime pain. No. All right, let's go back to the question. So according to this, there are no red flag symptoms. But that's kind of begging the question because one of the choices was a red flag symptom. Okay. What? Treatment includes regular consultations, reassurance, avoid gas producing foods. Okay. Okay, so the choice for cutaneous flushing says it's not viable because she hasn't had dyspnea and wheezing. But, I mean, that's not to say it hasn't metastasized yet. Yeah, so cutaneous flushing can be caused by carcinoids. Oh, that's the point. It hasn't metastasized yet. So at this point, I wouldn't have any flushing. Okay, how about weight loss? Crohn's disease. No, the choice was assuming celiac disease, but why wasn't Crohn's disease considered? Anyway, this is one of those weird questions. Okay, let's keep going. Okay. Patient is at greatest risk for which of the following? Previously healthy 22-year-old man comes to the doctor because of 1 week history of fever, fatigue, myalgia, sore throat, and difficulty swallowing. So this is a pharynx problem, or an upper laryngeal problem, or an upper esophageal problem. Let's see. He works as a tour guide, but he has been unable to go to work for the past 2 days because he is exhausted. He has no history of serious illness, takes no medications. He's lethargic. Temperature is high, 38.7. Febrile, pulse is 72. Blood pressure is 116/74. Neck and oropharynx show tender cervical lymphadenopathy. Erythematous, swollen tonsils with white exudates. Liver is palpated. It's 3 cm below the right costal margin. Spleen is large, 2 cm below the left costal margin. Hemoglobin concentration is 13. Leukocytes are 16,000. Blood smear shows atypical lymphocytosis. Heterophilus positive. Is at greatest risk for developing which of the following? He's 22. So maybe lymphocytic leukemia, acute lymphocytic leukemia is not really in the realm of possibility. Glomerulonephritis is out there. Burkitt's lymphoma. Atypical lymphocytosis. Oropharyngeal carcinoma, not really. Splenic rupture or Burkitt's lymphoma. I'd go with Burkitt's. Not even. Splenic rupture. Okay, so Burkitt's is more common in kids. Okay, I don't want to make another mistake for the rest of this block, but But it's all about learning. Plus, this was a 4-5 hammer block. Questions were especially hard. I don't think the questions are going to be that hard in the actual exam, or are they? Anyway. Oh gosh. These people on Discord are so funny. Okay, let's keep going. Patient's diagnosis is associated with which of the following conditions? 19-year-old man comes to the physician because of a 2-day history of blood-speckled stools and a protruding rectal mass. No pain, altered bowel habits, or fever. Mom has... He's only 19, by the way. Mom has IBD. Patient's vital signs are within normal limits. Examination shows hyperpigmented maculae on the lips, buccal mucosa, palms, and soles. He has a pedunculated polyp, superficial excoriations on the mucosa. Colonoscopy shows 14 polyps, and a biopsy shows hamartomatous. That's a fun word. Mucosal polyps. So, this is likely associated with what? Good question. So it's going to be alopecia, thyroid adenoma, pancreatic carcinoma, mandibular osteoma, intravascular fistula, or medulloblastoma. So wait, this is a mucosal problem. Would it be Poitsiegers, I think? Not sure. But anyway, it's a mucosal problem. So the problem would probably be associated with mucosal tissue, or maybe endoderm. Okay, let's rule out first all the ectoderm stuff. Medulloblastoma? No. Alopecia? No. Pancreatic thyroid carcinoma. Okay. Pancreatic in what sense? Because the middle part of the pancreas, the thyroid medulla, is ectoderm. But the outer part is... No, it's mesoderm. 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 Am I thinking fistula? Fistula. I don't know. I'm just going to choose that. No! But I was right about Poitsiegers syndrome. But what is the condition that is associated? Would it be thyroid? Medulla? Pancreatic? Pancreatic. Okay, so Poitsiegers is associated with pancreatic. But at this point, I have made more than 30% mistakes, which is sad, but at least I'm learning. Okay, let's keep going. I hope they don't have hammers in the NBME, in the Amboss assessment, step 2 assessment. But anyway, let's keep going. Most likely diagnosis of a 17-year-old boy brought to the physician because of a 12-day history of increasing pain and swelling of his right knee. Past 3 weeks, there's pain when urinating. Can't climb a tree. Can't eat. Is there any eye problems like conjunctivitis? Is an ankle joint resolved with treatment with 1 week ago? Mom has rheumatoid arthritis. He's sexually active with 2 female partners and uses condoms inconsistently. Let's see. Is there any eye problems? Anyway, it doesn't say anything. Okay, there's bilateral inflammation of the conjunctiva. Right knee is tender through nonetheless. Range of motion is limited by pain. Tenderness in the left Achilles tendon. Anesthesitis. ELISA is negative for HIV. Arthro is performed. There's leukocyte count, 70% neutrophils of 26,000. No organisms on gram state. I think it's reactive. Reactive! Got it. Okay, next. Confirm the diagnosis. 10-year-old girl brought to the doctor because of high-grade fever, myalgia, and fatigue of 3 days. She returned from a vacation to Botswana. She had chemoprophylaxis with chloroquine. Confirm the diagnosis with a blood smear. But wait. Temperature is 39, pulse is 110, blood pressure is 94 over 54, jaundice of the eyes and skin. Conjunctiva is a fun word to say, but it's a tongue twister. Spleen is palpated 2 to 3 centimeters. Yeah, do a blood smear. Blood smear, come on! What more tests do you need to do after a blood smear? Blood smear. Yes! Okay. Alright, let's keep going. Most likely blood types of the neonate and the mother. Hola. Blood types. Blood types. Blood types. Okay. Neonate and mom. Got it. So 2,500 female newborn, so pretty underweight, is delivered at term to a 23-year-old woman, gravida 2, para 2. There's copious yellow amniotic fluid. Ugh. Apgar score is 4 at 1 and 5 minutes. Mom did not receive any prenatal care. Pregnancy first was 2 years ago, uneventful. She spontaneously delivered a healthy girl at 40 weeks. Now this one's pulse is 85, that's pretty low. Respi is 20. Swollen, face, belly, pallor, and reduced muscle tone. Grimacing. Taken to the NICU for further care. Antiglobulin test shows immediate agglutination of red blood cells. So that's a direct antiglobulin. That means the baby's blood cells are either A, B, or AB. Okay. Oh! Okay, wait. The mom was 40 weeks in her previous pregnancy. For this pregnancy, she did not have any prenatal care. So that rules in the possibility of having a rhesus problem. So she could be rhesus positive, mommy. But likewise, it's possible that the baby has a RH, hemoglobin antibody that the mom doesn't have. So it's E. No! Okay, fine. C. C! Wait. I got the rhesus switched up. Should pay more attention to what I'm highlighting here. Anyway, let's keep going. Oh boy. I mean, I was on the right track. It's just that I got a bit dyslexic with the rhesus type. So here's my habit. I would like, oh gosh. How do I get over that thing? I don't think I'm actually dyslexic though. I need a formal diagnosis for that. But I don't think I am. Maybe I'm just attention deficit. No, I don't even know. Stop saying stuff. Anyway, let's go. Most appropriate next step in management. 5-year-old boy is brought to the physician by his mom for the evaluation of increased bruising for the past 3 weeks. 2 nosebleeds. Resolved spontaneously. He was born at term, healthy except for an episode of gastroenteritis 5 weeks ago that resolved without treatment. Patient is at the 48th percentile. And 43rd percentile. That's for height and weight, respectively. He is healthy, well nourished. Pulse is 100. Blood pressure is 100/65. There's a few scattered petechiae. It's fun to say. Petechiae on the trunk and back. Platelets are low. Can we do IVIG? 5-year-old boy. So it's not likely to be APAS. Platelet transfusion. It's not really that urgent right now. Splenectomy. No, not really. I mean, GI is normal, so exam is normal. So let's see. Do a Coombs. Did he get sick before? Possible. Observation. Corticosteroids or IVIG. Okay, so it's either Coombs or IVIG. No, it's not Coombs. It's IVIG. No, it's not IVIG. What is it? Oh my gosh. Just observation. But I was on the right track. It had ITP. But I thought you do it. Okay. So I am now at 60%. My block. I don't know what to think about that. Let's keep going. Most likely diagnosis. A 34-year-old woman comes to the emergency department with right flank pain and vomiting of 5 hours. She's had right flank pain and vomiting. Fever and chills for the past 2 days. Attended a barbecue 5 days ago. She ate an egg salad. No, that was 3 days ago. Underwent surgery a year ago. Menses occur at regular 28, last 5. She's 2 partners and uses condoms inconsistently. Medication is an OCP. 163 cm, 75 kilos. BMI is 28. It's uncomfortable. I'd be uncomfortable. Okay, temperature is 38.9. Pulse is 101. Blood pressure is normal, 118.76. Lungs are clear, right lower quadrant and right flank shows severe tenderness. Pelvic exam shows no abnormalities. Okay, what's the likely diagnosis? Let's go back. She's 34. She has RLQ pain and severe tenderness. There's a high leukocyte count. Oh, but there's a lot of leukocytes in the urine. Urinary tract infection could be caused by GI inflammation. Okay, wait. Let's take a step back. Is the urinary tract infection causing inflammation in the GI, or is infection in the GI causing inflammation in the urinary tract? I think gastroenteritis is my Best diagnosis here. No, it's not even. Pelvic inflammatory disease. Not even. Pyelonephritis. Back pain, fever, chills, nausea, vomiting, cystitis, urethritis, urinary frequency, and urgency are also often, but not always present. Urinalysis in pyelonephritis shows positive esterase, white blood cells, and YBC casts. Nitrites on urinalysis indicate infection with urea splitting. Okay, so what I had to do was look at the nitrites. Okay, so this is so nuanced. So the idea is if it was a foodborne infection that she got from the egg salad that was the primary infection. And because usually the food that the bacteria that you associated with this kind of food is Staphylococcus aureus, then you would have a high nitrite count. Okay, wait. It would be a positive nitrite count, which is not present in patients with pyelonephritis. But that's not supposed to be the takeaway I'm getting here. Okay, let's go to the first sentence. 34-year-old woman comes to the emergency department because of flank pain and vomiting. So am I supposed to walk away knowing that the first word that is mentioned is going to be related to your primary diagnosis? So if it said that she came to the emergency department because of vomiting and flank pain, then it's only in that case that it would be a GI infection? This is nuts. Anyway, let's move on. Most likely next step in management. Of a 43-year-old woman evaluated for worsening epigastric pain 2 days after admission to the hospital for gallstone removal. So epigastric pain 2 days after admission. By RCP. No complications. It's now constant and it radiates to the back. Should that give me a pancreatic hint? She vomited twice. She has hypertriglyceridemia. Okay. No family history of illness. She appears ill. Of course she looks ill, you poop. There's tenderness and the epigastric area and guarding. Leukocytes are at 1-250. Lipase is through the roof. Treatment IV is initiated. Let's give antibiotics. No, we don't do a surgical expiration. We can give pain meds, but we have to get to the bottom of this first. Calcium gluconate, not really. Imipenem, possible. Repeat RCP, possible. Is she already on antibiotics? Doesn't say. Let's give imipenem. No. Repeat RCP? No. Pain meds. Oh my gosh. Right. You cannot diagnose without if the patient is in super pain. Why did I miss that? Anyway, let's keep going. Nodes. That's the first thing I saw. Nodes. Okay. Chest X-ray. Which of the following is the likely causal organism? So a 39-year-old woman comes to the doctor because of fever, nausea, and non-productive cough. Non-productive cough of 7 days. He's had headaches, fatigue, muscle and joint pain, shortness of breath of 2 days. Diabetes mellitus, osteoarthritis. She takes insulin and ibuprofen. She smoked 2 packs of cigarettes daily for 20 years. Stopped 2 years ago. Temperature is 38. She has skin lesions with a livid center, pale intermediate zone, and a dark peripheral rim. Why am I tempted to answer mycoplasma pneumoniae? Well, okay. Let's go back to the case. She's had fever, nausea, non-productive cough. Keyword, non-productive. She's had generalized headaches, fatigue, muscle and joint pain, weakness, essentially. She has had shortness of breath. And she has the skin lesions. Okay, I'm thinking mycoplasma pneumonia. Sweet sauce! Okay, let's go. This is embarrassing. I got like 48%. Oh, 58%. At least. It's more than half. If it weren't for those meddling forehammers. Anyway. That's it, my friends. That was me studying today, and I hope you guys enjoyed seeing me in my suffering. Anyway, I hope to join you guys again. Until next time, guys, always remember to live life to the fullest because you only have one life to live. Okay, so we're looking at keratitis or retinitis or something in the itis. Wait, I have to do that again.